So welcome back. I'm excited to welcome our first listening session on issues related to population-based total cost of care models. Larry and the PCDT team helped us level set with helpful background information, including how previous proposals submitted to PTAC incorporated relevant components. Now we've invited 4 outside experts to give short presentations on their vision for population-based total cost of care models based on their experience. You can find their full biographies on the ASPE PTAC website. Their slides will be posted there after the public meeting as well. After all have presented, our committee members will have plenty of time to ask questions. So presenting first, we have Dr. Michael Chernu, who joins us from Harvard Medical School. Michael, I'll turn it over to you.
Thank you. It is wonderful to be here. I wish I could actually be there. Maybe you all wish you all could actually be there, but it is nice to see you, at least a subset of you I can see on my screen now. Thank you so much for having me. I will emphasize as I go through this that these thoughts are mine and mine alone. They don't affect they don't relate to, they don't reflect the views of Medpack. So understand that I'm speaking in my role as a professor, not as my role of chair of Medpack. I may say that multiple times. Okay, next slide. So let me just lay out something I think you all know, but I use it as a touchstone for me when I start talking, and that's sort of the broad theory of value-based payment, or for that matter, alternative payment models. The main view, at least my view, is efficiency in the healthcare system requires flexibility in how inputs are used. That's actually true of any industry. Efficiency requires us to be able to substitute some inputs for other inputs to get more output for less resource use. In the case of healthcare, we should think of healthcare services, hospital days, imaging procedures, lab tests, drugs, as those services are inputs. The output is actually health. So our basic goal for efficiency is to produce more health with fewer inputs. And the flexibility allows us to substitute those inputs to capture gains from efficiency, and that ends up being very important. So next slide. The challenge is that the fee-for-service system doesn't really encourage that type of flexibility, because you basically get paid for which inputs you use more so than the output that you get or anything like that. So our goals with alternative payment models is to create incentives to save, to become more efficient. And the key question related to a lot of the discussions we're going to have, I think, is who, by that I mean what type of provider, is best suited to eliminate whatever waste you believe there is in the healthcare system. We want to create incentives to promote access to care and quality and equity. Again, flexibility can help all of those goals. And we want to create incentives for organizations to participate in the models. I'll emphasize that participation is not a goal in and of itself, but any program of alternative payment models can't succeed without people participating in it. So in all these models, there's always this question of how you induce or mandate participation. How do you get people in while you meet your other goals? Next slide. So I'm going to make 2 main points today. In fact, when I'm done with this, maybe you'll hear some detail, but this is pretty much the conclusion in slide 3. The first point is no payment model is an island. When we have an environment that have payment models in them, they all interact because the delivery system is influenced by all the payment models that occur. So we often think about how well would a payment model perform against, say, nothing, but the real question is how well would a payment model function in the environment to which it's introduced, and that environment is seldom nothing. Which leads me to my second point, which is the APMs that we do have need to work together. We need to be aware of this sort of broad portfolio of models. Next slide. So when a lot of this current journey was launched into payment reform, we launched it under what I used to consider let many flowers bloom, test and diffuse paradigm. So the basic idea was you're going to have a lot of payment models. We were going to try a bunch of them by testing them. The ones that worked, you're going to let diffuse, and the ones that didn't, we weren't. It was complicated because knowing what the control group is was hard because the environment was changing. You never knew if you participated in a model, whether that model was going to continue. So every model had an uncertain future, which discouraged participation, and it tended to disincentivize savings because you don't want to make a big investment to succeed in a model that may get sunsetted. If you have a lot of models occurring at the same time, the savings might get siphoned away. What I mean by that is there's a certain amount of waste in the system, and when we set up a portfolio of payment models, we're essentially assigning the waste to a delivery organization. And if they can eliminate that waste, they get to share in some of the savings. But if we have a broad model, think population-based payment models, where the waste is assigned, for example, to an organization that employs the primary care physician, and then we take a portion of that waste and assign it to another model, say an episode model, that removes the potential savings that the ACO could have had from trying to eliminate the same waste. Now, they might not have done it, but you're reassigning where the waste goes, and that discourages participation and disincentivizes savings. So, for example, if you had a model that was assigned to, say, physicians to manage congestive heart failure, but you gave savings associated with anything post-hospitalization to, say, a hospital as opposed to, say, the cardiologist, just picking an example, you discourage the cardiologist from participating because you've taken a certain portion of waste in that stream and assigned it to some other entity. When you have a lot of models, participation via model selection can be gained. Some people might want to choose one model. Other people might want to choose another model if the models overlap in varying ways. And they can game them because there's often parameter differences, how the benchmarks are set, for example, what quality measures there are. And all of this leads to a situation where providers don't really commit to success because there's a lot of time focused on what models should I be in, what are the actual incentives in those models. So go to the next slide. So the sort of environment overall, and maybe I should have led with this, is there's waste in the American healthcare system. I don't think that's surprising to anybody, and we should view that waste as an asset. And when we set up these models, the different models, we're assigning that waste to different organizations. And when we do that, we create a series of both conflicts, like this slide illustrates the conflicts, and also incentive issues. Next slide. So some very, very basic evidence that I'm going to breeze through very quickly. I'm happy to talk about it more. Next slide. So in the case of population-based payment, here's my summary of the evidence. Population-based payment models, think ACOs, reduce spending, albeit by a small amount. The savings for admissions, a shift to outpatient as opposed to office as opposed to hospital outpatient departments, and there's a bunch of savings in post-acute care. There's some evidence of reduced use of low-value care. Independent physician groups kind of do better, often do better. My joke about that, I'm not sure it's funny, but anyway, is if your goal is to reduce hospitalization, it helps you if you're not a hospital. Results tend to improve over time. They never get huge, they just get bigger. And private sector models tend to do better. And part of the reason is in private sector models, there's a lot of variation in prices that doesn't exist in Medicare. So you can save in the private sector by how you steer patients more than you can save, for example, in Medicare. Medicare, you can still save by shifting sites, but it's not the same variation as you would see in the commercial sector. Importantly, and this shouldn't be surprising, but it seems to be surprising, in shared savings models, savings gets shared. I don't know why people don't pick up on the fact that you share savings in shared savings models, but it is odd. One interesting thing to remind everybody of their days in kindergarten, at least my days in kindergarten, is when you share something, you end up with less. That's the nature of sharing. So there are changes to behavior that requires less utilization of care. Those savings get shared. In most of these models, there's evidence that Medicare still saves some, but not as much as they would have because they've shared some of the savings. If you don't share the savings, there will not be incentives to create the savings that you want to share. I hope I never read the transcript on that sentence. Anyway, it's hard to know what this does for quality or equity. They seem to be the same or better, but I wouldn't claim that we measure that well enough that I should really emphasize those points. Next slide. There's also reasonable evidence on episode payments, and there is some savings in episodes. It very much depends on the episode. There's a lot of different types of episode, and of course, it also depends on the design. lower extremity joint episodes, for example, have seemed to have done well. In Arkansas, they had a big model. They saved some on perinatal episodes. The savings are not uniform across episodes. I wouldn't expect it to be uniform across episodes. The savings potential, for example, varies across episodes, and where the savings are varies across episodes. There's been a concern that there's going to be an increase in episode volume associated with this. In other words, you're not paying fee for service, you're paying fee for episode. We haven't seen a lot of empirical evidence of that. So actually, I'm less concerned that people are going to generate a lot of episodes. And again, we haven't seen a lot of evidence about strong consistent effects on quality. So I'm going to say the same thing I said about basically population-based payment models. It's hard to measure quality. I think my personal view is the evidence is reasonable. If we have time, or you can send me emails, I would love if you think anything in this lit review misstated the facts. I spend a lot of time trying to make sure that I get the evidence right, but the evidence is constantly evolving. So I'm interested in any thoughts you may have on that. Next slide. So when thinking about episodes versus population-based payment models, here's my quick summary. Both of them seem to lower spending, at least for some episodes and for some population-based models. Episodes are narrower, so if your goal is to get per member per month savings, that's harder to do in episodes because they're just influencing a smaller share of the spending. But not all practices can support population-based payment models, and episodes do engage specialists better. So if you think you need specialists involved to get the savings, you're not going to get savings if you don't get the neurologist, surgeon, cardiologist, you pick whatever specialty you want, oncologist involved. Episodes can, by allocating some of the savings, some of that waste as an asset to some of the specialists, it's possible you can increase the incentives for the specialists, and that might increase your savings overall. And there's some evidence that, in fact, if you have both, you can have a bigger pie of savings. And neither have a particular clear impact on quality. So the next slide. So let me give you a very brief model outline, and then I'll conclude. Next slide. So Medpack had a recommendation, and again, I'm speaking as me as a professor. This is just a statement of a Medpack recommendation. The recommendation was the secretary should implement a more harmonized portfolio of fewer alternative payment models that are designed to work together to support the strategic objectives of reducing spending and improving quality. What that essentially means is, instead of just launching models sort of as they come across the transom, one should think strategically about the portfolio of models that are launched, make sure they're harmonized. So you might not want 3 lower extremity joint episodes, for example. You might be careful if you started launching episode-based payment on top of ACOs, because every time you do, you siphon some of the savings away from the ACO towards the episode, things like that. So there should broadly be fewer types of models, and they should be designed in recognition that the others exist. Next slide. And so a very, very brief version of an outline of what payment might look like in 2026 or whenever. There will be a multi-track population-based payment model. The amount of risk could vary by size. So think, for just the purposes of conversation, something like MSSP, where you have a sort of high-powered track, a medium track, maybe a downside, an upside-only track, or some version of that. It should be designed in a way to avoid the ratchet in the benchmark. I wish I could spend more time talking about that, but what I basically mean is it becomes problematic if, when you save in one performance period, that lowers your benchmark in future performance periods. You basically just have lag penalization, so you're always competing against yourself. Eventually, that model will fail. And so you need to design the payment models in a way to avoid that ratchet. Once you have that multi-track population-based payment model, you want to add episodes because of the evidence that episodes can enhance the savings, but you have to do that carefully. You want to do it, for example, to avoid siphoning off too much of the savings. So, for example, if you thought ACOs were making a lot of the savings in reducing post-acute care, which is evidence is true, you have to be careful of giving that post-acute care savings potential to some other organization. Now, if they can expand the savings, it might work. So I'm not saying not to do it. I'm just saying be cognizant of how all the models are interacting. You want to focus on episodes with clear triggers, in my opinion, and you want to focus on episodes with limited ability of the primary care, the ACO, if you will, to influence the savings. You don't want to, in my view, give the population-based savings to an episode, because you'll discourage the population-based savings participation. from happening and from participation of those organizations. So there's a balance. In some ways, again, I'm speaking as me, but you'll see my connection here. I say this at Medpack a lot. Medpack is not CMMI. So Liz Fowler, for example, is a much, and her colleagues at CMS have a much more difficult job than I do, because we say sort of conceptually, here's how you might think about things, but the rubber hits the road when you actually have to make all these principles work in practice. So next slide, which I believe is just going to say end, or just be the end. Those are my comments, and I know you have two other outstanding speakers, both of whom are wonderful. So I will stop now. I think you're going to go straight through before asking questions of me, so I'm good with that.
Great. Thank you, Michael. Great presentation. Appreciate it. And yes, we're saving all questions from the committee until end of all presentations. So now we have Dr. Cheryl Damberg, who joins us from RAND's Center of Excellence on Health System Performance. Dr. Damberg.
Thanks, Paul. Can you hear me?
Yes.
Okay, terrific. So Mike is always a hard act to follow, but I'll do my best to fill in some of the gaps. Thank you so much for the opportunity to speak here today. I'm going to share with you sort of a summary of what I've observed both from my own research as well as that of others over the past couple of decades as we try to shift these payment models towards delivering more value in healthcare. So next slide, please. So Mike had already shared with you some of what has been learned. Some of it is duplicative on this slide. And this is sort of, covering a vast frontier of a lot of studies trying to make sense of what's been going on the street. So overall, we've seen modest savings, although with time, the magnitude of savings has in some cases increased. As Mike noted, quality performance has either sort of improved or largely stayed the same. But I would call out that even in the context of, say, the CMS ACOs, performing relative to Medicare Advantage in many cases. So there's still some distance to go there. The other thing to note, so these implemented in lots of different settings, and these contextual factors really matter in terms of both the settings and how they're structured. And some of the work that I've been doing here in California really underscores something that Mike noted in an article that so ACOs, or these entities that are being held accountable, they have incentives to lower spending on care that they actually don't provide. So what we see here in California is these large physician organizations, there are about 180 of them in the state of California, that are being held accountable for total cost of care. All of them accept financial risk for professional. Some of them accept global risk, but that tends to be a minority. But where they have looked to reduce spending has really been on the inpatient side. So it hasn't really affected their personal bottom line, if you will. The other thing that we see in the marketplace is that the uptake of these models has varied. Many of the high-cost players are not yet at the table. And I have to say, looking at the list of entities that signed up for the direct contracting, the most recent CMMI demonstration, I was actually kind of surprised at who I did not see at the table. So I think one of the things that various folks who understand what it's going to take to move this ball down the field needs to be doing is talking to the players who did not come to the table about why they're not coming to the table, and really understand that space, because a lot of the risk-bearing entities who have a lot of experience in this space were not at the table for that demonstration. So the question is, why are they sitting it out? The other thing to note, as we see a lot of these alternative payment models are built on a fee-for-service chassis. So there's lots of for bleed out and sort of challenges that providers face in managing the total cost of care for the beneficiaries or patients assigned to them. Next slide. So this is just here as a reminder as I move to the next slide, please. And I know you're all familiar with the land model. So, you know, my assessment looking at the results from the latest survey show that we still have a great distance to go to get to Category 4. And I have seen that personally in the work that I've done conducting interviews with health systems. And, you know, if you look at the results, you know, we still see, you know, close to 62% are still in categories 1 and 2 in that fee-for-service space. And even within the combined categories 3 and 4, where there's kind of a greater push towards total cost of care, much of that is still built on a fee-for-service chassis. So again, we are still not in this space of population-based payments as much as I think we'd all hoped we would be. Next slide. That my team has been doing over the past 5 years. We have been studying health systems in the United States and cataloging what they are doing to try to drive performance improvements. And those performance improvements cover total cost of care, clinical quality, as well as reducing low-value care. And we looked at large health systems. These are physician hospital health systems that have 50 or more physicians, of which at least 10 are primary care physicians. And when we looked at those who were participating in the Medicare ACOs, whether the one-sided or two-sided risk contracts, we find that a fairly small fraction of their beneficiaries are actually enrolled in these ACO arrangements. So the median, so 50% of the entities had 18% or fewer of their beneficiaries in these ACO contracts. And one of the things that we are seeing in our work is when we look at the correlation between beneficiaries who are in ACOs in these health systems, we are finding higher performance on clinical quality and better performance on lower value care. So trying to push those numbers upwards potentially can help drive the value part of the equation. So we would call that out. But the other thing, I guess, to note, and Mike referenced this, is that it's very hard to redirect attention and resources to population-based care delivery if only a small fraction of your patients are under these models. And the organization in different directions. Next slide, please. So we face some pretty strong headwinds, and this is because these health systems report that they're not able to advance the care redesign as rapidly as they'd like, given the small total share of their book of business that these value-based payment models represent. And when we queried them about what fraction of their total revenues were tied to these value-based payment arrangements, generally they would report, 5% or less. And these were very large organizations, sophisticated organizations. Oftentimes they were in markets where, at least on the commercial side, the commercial payers were not facing a lot of pressure from employers to shift toward those models. So they are kind of still operating in this fee-for-service space. And because they have so many different payment models that they face from Medicaid, Medicare, and the commercial side, they're trying to figure out how to balance all these different incentives. So what do? They're playing to the middle. And right now that middle is skewed heavily to the left side of that land framework toward fee-for-service delivery. Next slide, please. So this was a study that my colleagues and I recently published that describes sort of what the frontline physicians in these large health systems are facing. And again, it's really still a fee-for-service world for the front line. The size of the incentives are very, very small for anything around total cost of care. In most cases, that was missing from what they were held accountable for. The incentives tended to focus mostly on things like clinical quality, patient experience, and other types of things, including increasing the volume of patients moving through the system. So again, these headwinds are pretty significant. Let's go on to the next slide. So one of the things that I think folks around this table are probably aware is that we've seen a lot of restructuring in healthcare markets. And a lot of that's being prompted by these payment reforms. And the different payment reforms that the ACA kind of unleashed contributed to significant vertical consolidation in the market, with these hospital and health systems buying up previously independent physician practices in their communities, as well as across communities. And when we spoke to them, we asked them why this is happening. And most of them reported that they really needed to beef up their size to be able to spread and manage financial risk, despite the fact that, most of them were not actually taking on that much risk at this point in time. They also talked about the need to offset loss of revenue that a lot of these total cost of care value-based contracts, place on them to reduce spending. And lastly, and importantly, to bring greater leverage in price negotiations with payers. And, a lot of this vertical integration or management, it's happening also through these contractual relationships that are driving up prices in various markets. Next slide, please. So, there are a number of proposed benefits of this type of vertical integration, whether it's lowering administrative costs, improving the care delivery infrastructure to try to deliver better quality at lower cost, and last but not least, working to improve clinical integration and the coordination of care across providers within a system. And if we go to the next slide, our work has found that it's an assumption that vertical integration is going to actually produce clinical integration. And, there's different forms of integration, and most organizations are coming together structurally through ownership or management of operating units. The functional integration, which is evidenced by the extent to which the health system has more centralized control versus there's autonomy of the entities within the system. Some of that can be effectuated through centralized decision-making or can be effectuated through softer incentives and branding kind of mechanisms. And health systems really vary in terms of how much they're putting sort of that hard versus softer integration into play. And then last but not least, and I think what we're all trying to work toward, is better clinical integration. Evidence through the presence of organized processes to control costs and improve quality. And that can be through hardwired clinical processes, standardized service lines, redesigning care delivery, formal protocols or processes. And systems are really struggling with this. And the executives we spoke with told us that clinical integration is the building block for better performance. But as we see from the next slide, so this clinical integration has been really hard for them to achieve. And most of them would admit that this has largely not been achieved, that they have not achieved standardization across their entities within their systems. And, this is a function of many things. Changing physician practice patterns is hard. They don't necessarily have the structures in place to do that coordination across different settings. But I think of interest to this committee, if you look to the right of the slide, they repeatedly reported that the pace of payment reform is too slow to be transformative, to make the investments that they need to transform care. Next slide, please. So I'm going to shift gears just quickly. So as somebody who has spent time trying to evaluate these programs over the years, there's a mix of both quantitative and qualitative work that needs to be done. But I think most folks who operate in the evaluation space know that a lot of these voluntary models have been very problematic to evaluate because of selection issues related to who chooses to participate, and that the entities who sign up are likely those who are going to be most likely to succeed, and the challenges of finding good comparison groups. So those are among the various challenges, but also that are really trying to advance many of the same types of end objectives. It's very hard to isolate the effect of any single alternative payment model being tested when there's so many other reforms that are in play. And despite the fact that the Office of the Actuary needs to understand kind of how much savings has been accrued to decide whether a model continues and moves into real time, that has been a very challenging space to navigate for them. But I would say this, if you think about how the real world operates, generally they learn by doing and adjusting. And so I do think that there needs to be greater emphasis put on qualitative work to try to understand a lot of these contextual factors that affect results, but also can help spotlight how to improve the effectiveness of these different payment models moving forward. Next slide, please. So in terms of what's needed moving forward, I do think that it would be helpful to the providers on the street to narrow the payment options to help bring greater focus. When I talk to physician organizations and health systems, they're staring down more than 200 quality measures, and they don't feel like they could ask their frontline physicians to focus on any more than a handful. Again, they're really struggling with thinking through what share of their revenue is coming from which sources and which incentive to pay attention to. We also need to think about the incentives to reduce spending and whether they're high enough to not only induce participation, but also cover the costs of participating and the types of investments that providers have to make to move to that next step. I would encourage CMMI to, as well as private payers, to emphasize testing of models that really start to shift toward true population-based payment. I think we've seen very few of those models, and direct contracting is one such model, but I hope that there would be other such wholesale type models tested in the future. I would, again, encourage mandatory participation to be able to bet some of these impacts, to understand what's happening, to avoid those selection issues. And as I noted on that last slide, we really need to beef up the qualitative work to understand these real-time learnings to make adjustments as we go. So with that, I'm going to close, and thank you so much for the opportunity to share what we've been learning.
Thank you, Cheryl. Appreciate the great presentation. Next, we have Mike Edelberg, who joins us from Fager Drinker Consulting. Mike, I'm going to turn it over to you.
Okay, well, thank you. It's a pleasure getting a chance to speak with the panel, and certainly I'm honored to get a chance to be in the company of Drs. Chernew and Edelberg. The focus of my slides is a little bit different in that I work primarily with health plans in the Medicare Advantage program. I'm going to talk to you a little bit about best practices in terms of affordability and driving high value care in that program that might be helpful to the committee as it thinks about the evolution of total cost of care models. Next slide, please. So just a little bit about me, because I may not be known to the committee. I've been in and around the Medicare program for the last 25 years, includes 15 years at CMS, different senior positions, also spent a number of years at a health plan. And I currently lead or co-lead consortia of provider-owned health plans focused on improving their benefits packages and improving their provider network administration. Next slide, please. Okay, so a couple of assumptions going in. We're going to look at the levers that are available to plans and assume that these levers raise and lower utilization and can impact the activity of members. And of course, when we think about ACOs and direct contracting entities, again, some of these levers in this toolbox may be available today, and some of these levers and tools in the toolbox may be available in future models. But the assumption here is that by promoting high value utilization, we can improve outcomes, we can drive down waste, and all of that frees up money that can be paid to create more generous benefit packages and sort of create a positive cycle going forward. Next slide, please. So we know a number of things about the Medicare beneficiary population. We know that it is a cost-sensitive population, and that Medicare beneficiaries, when they feel price pressure, will underutilize. Certainly it's well documented activities of, particularly with drugs, but also other services with respect to pill splitting and underdosing when people feel price pressure. We also know that health literacy is limited. So there have been tests, for example, looking at a $20 copay versus 10% coinsurance, and people presume that 10% coinsurance is better coverage than a $20 copay, and of course that is rarely the case. And they're underlying all of this, as whether they be direct contracting entities or succeeding models, the economics that drive an MA plan in a capitated environment and full risk, more and more providers are going to experience similar, if not the same, dynamics. And so we're going to look then specifically at some of the tools available to health plans. Next slide, please. Okay, so how can plans encourage high-value care? Certainly, cost sharing is a big piece of that. In recent years, we've seen more and more Medicare Advantage plans make $0 primary care available, make $0 generic drugs available. We're seeing more and more plans experimenting with different types of reward programs. For example, gift card to get your flu shot, targeted OTC supplies, etc. We're seeing more and more condition-specific benefits. The idea here is if you have someone, let's say, with kidney failure who needs to get dialysis 3 times a week, make it easy for them by putting them in a car to get to their dialysis facility. We're also seeing a lot being done with healthy groceries now, again, to help people more successfully manage their chronic conditions. Flexibility that CMS created in 2018, but has had relatively low uptake, but I think may be particularly interesting to the committee, is the high-value provider flexibility. This allows the plan to measure its network providers, and based on that measure, whether it be a set of HEDIS scores or low readmission rates or whatever else the plan selects, to then lower cost sharing or create an additional supplemental benefit that will encourage members to utilize that subset of the provider network. So if you have 10 primary care docs, but 4 of them are helping you get to the key star rating, you can have a set of benefits and services that incent your health plan members to utilize those 4 primary care docs rather than all 10. There's also a lever that's coming online next year, was tentatively introduced this year, which are the real-time benefit tools specific to Part D. These are tools that will be available to all members next year, whereby the drug formulary is ingested into a tool, for a smartphone app, for example. And that tool, when a script gets written, will understand the least expensive, clinically appropriate drug and stimulate a conversation between the provider and the member as to whether a lower cost script can be written. We know that if the lower cost script is written, the member saves money on cost sharing, the plan saves money on its costs, and we know medication adherence goes up because the drug is more affordable. Next slide, please. We also know that plans have a toolbox for discouraging low value utilization. And this again includes cost sharing. It can also include using deductibles. Using deductibles, of course, a controversial practice in that, yes, you might be discouraging low value utilization, but along the way, you may be discouraging quite a bit of high value utilization. And then there are the utilization management tools, which include prior auth. And we know that CMS in the original Medicare is using more and more prior auth, most recently the national expansion of ResNat, and step therapies, particularly with respect to drug utilization. In both cases, and I suspect everyone on the committee has their own opinions about these utilization management tools and how they're often implemented. There are legitimate concerns about how these tools have been implemented. There was a concerning study, for example, in Health Affairs published last year, which showed that in the studied step therapies, the majority of step therapy protocols are not synced up to clinical guidelines. So I don't want to suggest that these utilization management tools are without their flaws, but they are used because they do disincent and discourage low value care. Next slide, please. Medicare Advantage plans are increasingly interested in addressing social needs and the social determinants of health. A great many plans now, in one way or another, contract with a social service referral platform. There are a number of these that exist. And the idea is, as the health plan becomes aware that a member is struggling to pay rent, is struggling with their bills, is struggling to get reliable transportation, the health plan plugs that member into the social safety net programs that exist at the community level. Now, obviously, our fraying and under-resourced social safety net cannot always meet the needs of these individuals, but in many cases it can. And then the plans are experimenting, and more plans are offering some form of healthy food assistance, some form of transportation assistance, in-home supports, friendly visiting, and light house chores, socialization activities, and even mild home modifications from air conditioning to putting in home safety devices, and mild home modifications like, for example, grip bars in a shower, stair rails in a hallway, swapping out drawer pulls so that people don't fall when they are attempting to open a drawer or medicine chest in need of repair. The book on these are all very new. How many of these produce the efficiencies that we're all looking, we have to learn that. We know that these are worthwhile experiments, but we don't have a rich body of evidence yet on most of these activities with respect to whether they do ultimately prove to be self-financing in the form of relatively low investment in the activity, costs avoided as a result of the activity. Next slide, please. The Medicare Advantage plans also are in a competitive marketplace, and they are seeking to acquire members. So while perhaps in a perfect world, every penny invested in additional services by an MA plan would solely be focused on improving high-value care, improving health outcomes, we know that marketing value is one of the reasons that plans invest in these benefits. And there are certain benefits that I suspect do not significantly add to high value utilization. That includes the Part B premium buy down, which is marketed aggressively during MA enrollment season. And arguably, it also includes the very popular gym benefits that most plans include, but we know utilization is very low. I don't mean to criticize fitness benefits that are well utilized, but not all of them are well utilized. Next slide, please. So all of this is powered by the actuarial exercise of cost offsetting. Actuaries have worked with cost offsetting for many years. We know, for example, that when actuaries have grown comfortable with the idea that when you lower cost sharing for a drug, adherence is going to increase. And there's comfort, at least with certain more predictable chronic diseases, that with increased adherence comes a slower progression of that disease and savings resulting from that. What the actuarial profession is still gaining comfort with is the cost offsetting from these non-traditional and non-medical investments. Here, the idea that transporting someone to a dialysis facility should result in less missed dialysis appointments. With less missed dialysis appointments, we would have fewer hospital-based emergency dialysis episodes of care. So it makes sense that there would be some cost offsetting associated with the cost of transportation. But this is all fairly new, and the actuarial profession is still coming to grips with this other type of cost offsetting exercise. Ultimately, whether it be a health plan or whether it be a provider in a full risk environment, the incentives would be the same. What are you going to invest in up front that ultimately proves self-financing because of the costs avoided when you make this investment? And together, we're all going to have to get better at this. The body of literature is going to have to improve. We're going to have to develop forums for sharing successful practices. But ultimately, to me, it's a very exciting place to be, and certainly it's very rewarding for me to get a chance to work with some plans on that type of modeling. Next slide, please. And so with that, those are my remarks today, and I'm very happy to stay around for Q&A later. Thank you.
Great. Thanks, Mike. Great presentation. And so for our last listening session, I'm going to turn to Chris DeMars, who joins us from the Oregon Health Authority. Chris, turning it over to you.
Thank you so much. So hi, everyone. I'm, as Paul just said, Chris DeMars, Oregon Health Authority, Interim Director of Delivery Systems Innovation and the Transformation Center Director. And I don't see the slides yet, so I'm going to
One
wait.
second, they're coming up.
Okay, sure thing. So while we're waiting, today I'm obviously kind of taking a different tact as well. I'm providing the perspective or experience that Oregon has been on through our health system reform journey. I will just be focusing on part of it, but I'm going to try to have a kind of get through a number of years of history and also our vision within the next 10 minutes or so. So next slide. So first, I'll start with an overview of our coordinated care organization model, which is focused on Medicaid, and then talk about our vision for a multi-payer reform, focusing on 3 specific initiatives: our healthcare cost growth target work, spreading value-based payment, which is a term we use for APMs across all payers and providers, and a regional multi-payer global budget pilot that's currently under development. Next slide. So Oregon's CCOs, Coordinated Care Organizations, were established in 2012, so we're about 10 years in. These are community-governed organizations that bring together physical, behavioral, and dental health providers to coordinate care for our Medicaid plan, which we call the Oregon Health Plan. It's about 25% of the state, and about 90% of Medicaid members receive care through a CCO, and the distinguishing aspects of the model are CCOs receive a fixed monthly blended budget from the state to coordinate this care for their members, and it grows at 3.4% a year. And we have an 1115 waiver for this model. I should have mentioned that. They receive financial incentives via metrics that they need to achieve benchmarks or improvement targets on, and it's a kind of pay for performance component of the model. They receive a blended budget that I already mentioned, but that gives them flexibility to address their members' health needs or kind of social needs beyond traditional medical services, and we call these health-related services. And some examples are like short-term housing or cooking classes, etc., mental health programs within schools. And then the model's designed to improve member care and to reduce costs. So next slide. So we've seen significant progress in both quality and costs, and the data here is a little bit old, but generally we're still seeing these outcomes. And so with regard to the incentive metrics that I touched upon, you see the performance on adolescent well care visits and depression screening. Our emergency department visits are down, and it's just going in the right direction with regard to quality, and while also lowering costs. And we've saved well over now $2 billion. We haven't tracked for a number of years, but we know compared to the cost growth that we were on at 5.4% when CCOs were put in place, and the agreement we have through our 1115 waiver was, as I said, to limit that to 3.4%. We save a lot of money, and also about 94% of people in Oregon are insured. So all of that being said, it's going in the right direction. We know we still have quite a bit to do related to costs and VBP, social determinants of health, or health-related social needs, and health inequities. So next slide. So kind of stepping back and providing some context for our vision, and many of you probably know this as well, that countries with high-performing systems share 4 attributes: affordable, universal coverage, high value and primary care. They invest in social services and decrease administrative burden. So next slide. And we have been making some progress in these areas with regard to affordable care. We expanded under the ACA, launched the statewide cost growth target, which I'll be touching upon. With regard to social determinants of health, I already mentioned the health-related services, and CCOs are working with community-based organizations, and we have lots of demonstrated examples of that. High value in primary care, we have a patient-centered medical home model that we call the patient-centered primary care home program that's been very, very effective. We have a prioritized list of health services that promotes high value care. And we're kind of taking the CCO model and we're started to spread some components of that to our public employee plans. And then in administrative simplicity, we have a statewide committee that is trying to identify metrics to be adopted by all payers in the state. I'll be talking a little bit about spreading value-based payments. And then also the Oregon Health Authority has health programs, the public health programs, all in one agency, which happened a few years ago and has really helped around administrative simplicity as well. So next slide. And one other kind of component or context setting is that in 2020, Oregon established a 10-year goal, their Oregon Health Authority established a 10-year goal to eliminate health inequities. Yes, it's very bold, but we thought we would set the bar high. And the rest of the slide provides our definition of health equity. I won't read that, but you can reference that if you're interested. So next slide. So then looking forward, we know to achieve this goal, the health equity goal, we need to create a simpler system that's focused on equity. So what you see here is our vision that everyone, not just Medicaid members, are insured and have access to affordable care. Everyone has access to high value benefits and culturally responsive care that promotes equity, primary care, and prevention. That the entire health system uses a fixed total cost of care global budget and has the flexibility to address social needs, and that plans are designed, plan designs contracts are aligned with common expectations for equity, quality, access, and cost containment. So next slide, please. So our initiatives to achieve this vision, we kind of are knitting a number of different initiatives together. So first is to achieve virtually universal coverage. We're striving toward 98%. You've seen the previous slide, we're about at 94%. I'm not going to be talking about those initiatives today, but just know that that's kind of a backdrop here. Implementing the statewide cost growth target, and then just, delivery system and market reforms around value-based payment and aligning across markets and piloting a regional multi-payer global budget. And I'll be talking about those in the next slides. So next slide, please. So first is the statewide cost growth target that was established through legislation in 2019 that set a cost growth target for the entire state starting in 2021 for 10 years. And that target is at the 3.4%, which is, you might remember I mentioned that that's where CCOs had started out, and then kind of limiting that further starting in 2026 to 3%, and we've just done the projections for the first 5 years, and we're projected to save $16 billion over that time. Next slide. So the Cost Growth Target Committee that was established through the legislation I mentioned, they recommended principles to adopt advanced value-based payment as their kind of first strategy to put in place to help meet this cost growth target statewide. And as a result of that, we've recently put in place last year a statewide, what we call a value-based payment compact, which has goals around or targets for all payers and providers in the state. And next slide, please. So to provide just a little more context setting for this VBP compact, CCOs have requirements around value-based payment that began with their 5-year contract that started in 2020. And the bottom line is, I won't get into detail on this, but the bottom line is CCOs have targets and they need to achieve that start with land category 2C, so pay for performance on up, and to have 70% of their global budget be paid out to their contracted providers in the form of value-based payment by 2024. And there are also some PMPM requirements for them to pay their patient-centered medical home clinics, and then they need to develop a value-based payment in one of 5 what we call care delivery areas to give them more experience in VBPs. So next slide. So then now going back to the VBP compact that we just put in place. These are voluntary targets, but, and I'll get into the adoption so far in the next slide, but they are also more aggressive than the CCO requirements. So I mentioned the CCO requirements started with pay for performance or LAN 2C. For the VBP compact, the targets start at, for all payments, start at category 3A shared savings, and we're striving toward, as you see, 70% by 2024. And then for primary care and hospitals, their targets are focused on shared risks. So LAN 3B at kind of this, that reaching also 70% by 2024. Next slide. So I mentioned the compact was put in place last year. At the end of last year, we had wonderful adoption of this voluntary compact. We'll be tracking obviously over the next number of years to see if it's actually successful. But we have all major payers that have signed on, and this accounts for almost 3/4 of all lives in Oregon. The self-insured kind of lives is the biggest chunk that's missing. Next slide. So now moving toward kind of our vision that I kind of like moving forward. So the VBP compact was our first step at true alignment across all payers and providers toward our vision. And so now we want to further align across markets. And this slide shows the lives that are under the state. And we really want to focus on getting the state lives kind of aligned, or the state programs, the state lines of business aligned, and then move forward. So what you see here is about 1/3 of the lives in Oregon are under either Medicaid, or public employees, or educators, or the health insurance marketplace. Next slide. So the alignment across markets, we're looking to align total cost of care. I've already talked about the value-based payments and global budgets, accountability toward equity, quality. These would be tracked through metrics and outcomes, including addressing social needs, and then also really promoting community voice. In the alignment, we are looking to engage communities in the health system design and accountability. Next slide. And kind of more the initiative that's underway to kind of play out this vision is in 2020 at our legislative session. The legislature passed a bill to require the Oregon Health Authority to design a plan for a pilot of a multi-payer global budget. So as you see here, we have the state lines of business, the 3 umbrellas on the left, and our goal is to bring in Medicare, and we've had some initial conversations with CMMI about this, and also bring in commercial payers. And so the preliminary plan is that we just started working on this over the last few months, is we'd start with a budget for payers in a defined geographic region to cover the total cost of care for their members, and then pair this budget with aligned expectations for promoting equity, quality, community engagement, the VBP compact requirements, the VBP compact targets, and actually have them become requirements as opposed to voluntary. All purchasers would pay their payers a global budget that would grow at the same fixed rate, and then we trend this forward at an annual fixed rate. So the results that we're looking for is more equitable access to quality care for people across all insurance plans, improved access to preventive and health-related social needs, and cost containment and smarter spending. So that's our vision in Oregon. Thanks for letting me share our what we're striving toward.
That's great. Thank you so much, Chris. And thank you to all our panelists for sharing your insights and experiences with us today. Really covered a lot of ground. So I'd like to now open up the discussion to our committee members for questions.
Yeah, this is Angelo. I'd like to make a comment and pose a question. So again, just great congratulations to Chris and the Oregon model. It's just very impressive work. And throughout the presentations, I think several highlights were made, which has been my experience as I've worked with other networks, and that is that there is a lack of enough patients with any given network to really accommodate their willingness to redirect their care model. So that's a big issue across networks that I've dealt with. And there's, on top of that, not a clearly successful care model that's implementable at a primary care level or a smaller network that's not an Oregon type model that's, kind of state supported. And so since that care model isn't clear to them, there's not enough upside on most of the contracts to cover the cost of implementing something that there's questions about. Those two things combined create the hesitancy for most networks to want to really get into value-based care where there's significant global risk associated with that. And so that was well outlined in the discussions, but my question to you all is, so what do you think recommendations to PTAC and CMMI would be to get past those two things? Is it an all-payer model? Is it standardizing the care model, best practice? How do you see getting past those so we can get more value-based care implemented across the country? And I'll pose that to any one of the presenters.
That's a big question. I'll say very quickly, and then I'll leave to the other presenters. First, I agree that that's a large problem. In fact, in many ways, it becomes a bigger problem as Medicare Advantage grows because there's fewer people in fee-for-service. And when we think about ACOs, most of these models are only there. I think that that's one motivation for having fewer, more harmonized models, so you aren't dividing what you have across different types of models. I think there's some merit in doing things in states like Oregon where they're trying to bring them together. I think it is going to be hard for CMS and CMMI to do multi-state models, so I think collaborating when possible with states that are doing it is actually a good thing. It's hard to push them into it. It's easy to participate when they want to do that. And hopefully there can be models that have more incentives to participate, and that the providers will work with their payers to try and move synchronization of the incentives that they face. But that is, of course, challenging because when the providers are not integrated, and Cheryl talked about the integration, you have a problem, for example, in an ACO model that's based on, say, an independent physician organization. How are you paying the hospitals? And they tend to be still paid in some fee-for-service basis. It's how you engage them matters. So I think there's a lot of work to be done in those spaces, and I think I would expect going forward they were going to make progress incrementally as opposed to revolutionary, or some sort of big revolutionary way. It's just hard to move that many contracts with that many payers in that many ways simultaneously. So I think starting with a strong vision of where we're going and a set of models that work, and hoping that much of the other system, including the state-based payers, can work around that is probably the best I can do. And I somehow feel that wasn't very good.
Thank you.
Any comments from the other presenters on that question? You're on mute, Cheryl. Sorry. You're still on mute.
All right, can you hear me now?
Yeah, that's great. Yep.
Okay. So that's really strange because I'm calling in through my phone. So I would agree with what Mike said, but I do think that the extent to which Oregon is able to make some inroads on this front by bringing together the different payers to agree on some common standards for how they're going to proceed. I've seen the value of that in California, And, most of the time I don't see all the different payers in the marketplace, including Medicaid and Medicare, coming to the table with the private payers to decide sort of how things should play out. So whether that's alignment on measures or kind of how providers are paid and what they're incentivizing, I think there's still an opportunity for greater collaboration and coordination than currently exists, because there's just so much noise in the marketplace. And personally, I don't know how providers kind of manage it all. And I think for the most part, they're not. So we're not getting the results that we want.
Great, thanks, Cheryl. Other questions from committee members?
I have a question. Can you hear me? Because I'm talking through my phone.
Yes, we can hear you, Larry.
Okay. All right. So our session these 2 days is on the definition of total cost of care. The 4 presentations provoked a lot of thought, but I don't have a clear definition from each of you on total cost of care. I wonder if we could come up with some concise statement from each of you as what you view as total cost of care.
If we're going in order, I'll say something that might be straightforward. Others can correct me. It's good to go first and get corrected. I view it as the total, essentially, per member per month that's paid on behalf of a beneficiary, either by their plan or by the beneficiary themselves, or by any supplemental coverage or any other coverage. So you take a beneficiary, say Larry, you look at all the money that is paid on his behalf to a provider. That's a total cost of care. And I would do it for all services. I would do it for a period of time, a month, a year, some version of that. Others can tell me, you can tell me, what am I missing?
And you include pharmaceuticals.
I would include pharmaceuticals. That's why it's total.
Okay.
Yeah, it's total spend.
Well, I would certainly agree with that, but I'd also note that as we think more about closing health equity gaps and social determinants of health, increasingly we're tempted to make investments outside of a medical service in the interest of making the medical spend more efficient. And as we think about this holistically, I'd encourage us to, whatever definition we land on, to accommodate the possibility that diverting some amount of funds from the medical spend in the interest of helping the medical spend is a concept we should be working with.
I have a thought there, but Mike, looks like you're going to speak. No.
I think that providers that are paid under these kind of global budget models, for example, let's take the most extreme case, Kaiser. They can choose how to allocate resources, whether it's towards their doctors or medications or, buying food for seniors.
I agree with that. I don't think we could increase the budgets of these models to include extra for all the other things that people buy, housing, food, etc. But if you want to reallocate in a target, that's fine. I think, Larry, the point you're raising about drugs is right. I would define drugs as part of total cost of care. But for example, in Medicare, where you're paying through that separately through Part D, the models aren't really true total cost of care models. I don't worry a ton about that, by the way, in the grand scheme of things. But there's a slight difference between what I define as total cost of care and how I would put these, say, population-based payment models in place in practice, because they do tend to have some nuances based on the way coverage plays out. So if you carve out mental health I would clearly put under total cost of care. But if you carve it out, it's going to be hard for a payer to have a total cost of care contract if they aren't responsible in the grand scheme of things for total cost of care. In Kaiser's case, if they're responsible for everything with nothing carved out, then you can get to a truer total cost of care model.
And I'll just say in Oregon, we're seeing, as I mentioned, the health-related services, and CCOs have the ability to pay for health, needs beyond the traditional medical care, and we're seeing costs go down. And what we're hearing is they're focusing on their high-cost patients and providing them the care and supports they need, the care coordination. We have community health workers, et cetera. And so I think providing that flexibility really helps you get at both the quality increase and cost decrease.
Just going to add a follow-on question to all of that. So, Mike, you talked about the tremendous investment from Medicare Advantage into social determinant of health platforms and referrals. I'm curious what each of you are seeing as the highest value investments to impact equity and social determinants. So what I see around the country is a big movement towards housing is healthcare, and some really interesting outcomes related to that. But I'm curious from each of you what you would see as best recommendations for where to invest if we start to look at in total cost of care, social needs.
Well, I'll take a shot, but I'm sure my co-panelists will have additional and perhaps ultimately more valuable responses. I liken this to, it's a 5,000 piece jigsaw puzzle, and we've put about 20 pieces in so far. And so there are these little use cases. I do think there's some good actuarial study, and there are some peer-reviewed articles around transportation for kidney failure. There's recently been a handful of studies related to Medicaid programs to short-term housing support, supportive housing short-term. There are a couple things related to food, but there are all these very use case specific scenarios. Now, I'm not aware of any type of meta understanding of when to do this. We're still very young in all of this. I would note that all of this is confounded by the diversity of our social service safety net. So what would work in one state, because the social service safety net is so different in another state, there's this added layer of complexity that what might work in Oregon can't automatically be transferred to Kansas.
If I could add two things, and I agree with what Mike said. The first one is, what evidence we have is growing, and it needs to grow not just in volume, but in rigor in some ways. The Camden Coalition experience is one that I would point to, where the randomized trial didn't give you some of the results that you got in the earlier reports. By the way, I'm a fan of the Camden Coalition work. It's just understanding the evaluation point is difficult because of a bunch of selection and other issues. The second thing I would say is, if your goal is to save money or even improve quality, targeting is crucial. It's not that, say, transportation or housing works. It's all about who you target to get it and how you get it to them and how you engage them. So the operationalization of these things matters crucially. And I guess the third thing I'll say is, it really shouldn't be all about saving money. We often evaluate these things and say they save money. We don't think about the same, for example, in oncology care or a bunch of other care. We have a healthcare system to make people better off. And so I don't think we should abandon things that improve people's well-being but don't necessarily save money. That said, there are fiscal constraints, and there's complicated questions about whether the healthcare system, for example, should be responsible for these things, or whether other aspects of the social safety net should, and how do you have the healthcare system wrap around what exists or work with what exists. These are all very complicated questions, because you can envision expanding our payment models into areas that are well outside of the area of expertise of the organizations that are managing these. So the flexibility to do them the way Mike emphasized, I think, is important. And I think it's clear that certain places, Oregon, I'm sure Kaiser, other places, a lot of MA plans are doing that. I would be cautious about how we try to institutionalize that is a fundamental role for the healthcare system. I'm afraid we'll create the wrong metrics of success, and we will turn over the responsibility to organizations that might historically not have been focused and sort of set up to meet those goals.
I'm going to add two things to what has already been said. I think generally we're not necessarily meeting people where they're at. And by that, I mean, some of the people who are the hardest to reach often cannot, receive care in a 8 to 5 space of time. And I think health systems that have demonstrated more flexibility in terms of offering primary care services after hours into the evening, walk-ins, have been more successful in getting people in for needed services. So I would spotlight that space and how are we incentivizing that type of flexibility in care delivery? The second thing I would flag is that in various communities around the United States, we have what I refer to as ambulatory care deserts. And so individuals who want to obtain primary care and even specialty care have to go great distances outside their communities and oftentimes have very difficult time accessing providers who can assist them. So, and I think that's largely a function of payment rates to individuals in those communities, such as in Medicaid, are so low that providers don't have any interest in serving those communities. And so I think we have to think carefully about sort of the structural racism that's been built in based on our payment policies.
Great.
And I could just add a few other.
Yeah, please.
I couldn't get off mute. So with regard to the kind of partnerships between the healthcare system and the social service or community-based organization system, what we're seeing is there are culture issues. Bringing these entities together requires capacity building and maybe even some convening that needs to happen. And then there also needs to be kind of the data piece is really important. So in Oregon, we just developed a social needs screening metric that we're hoping to put in place soon. And so that would be kind of screening patients in providers' offices and then referring them to get their needs met around housing, transportation, and food. And in order to do that well, we're hoping to build kind of a statewide, this is happening in pockets, but statewide community information exchange between the healthcare system and the CBOs. So that's one other point. And then the last point I'll mention here is I think should think about social risk adjustment. That's an area that we've looked into, and the data are not there to kind of indicate what model to adopt, but it's something that I think is really important to put in place when you have a payment model to make sure that the providers are receiving adequate payments for members that have kind of high needs to be able to address their social needs.
Very valuable comments. Thank you so much.
Thank you. Other questions from the committee?
Yeah, can I just follow on that last comment?
Oh, sorry. No.
And I'm not trying to spotlight my own work, but we have looked at trying to do what I call some post adjustments to payment related to social risk factors, because the underlying concern is particularly around pay for performance or some of these value-based payments is, they tend to reward the kind of more affluent groups who often have lower percentages of people of color, people of low SES backgrounds, and so on. So I do think that both private and public payers need to be thinking about some of these back-end adjustments that can occur related to these value-based payment approaches.
And REACH does do a version of that, by the way. If you look at the new REACH model, they've tried to separate the utilization from the amount of money. You can discuss how they are trying to do that.
Yeah.
Great, thank you for that. Other questions?
Well, one question I'd like to ask Mike, as well as the rest of the panelists, is, you guys touched upon this. When you think about harmonizing APM models and trying to engage specialists, besides having a shared sort of profitability pool, like a integrated system, some of the challenges are, if you do episodic care and you nest it inside an ACO, how do you think about polyconditions, right? How do you think about people with multiple conditions and the triggers for that? So I'd love to hear some thoughts on, what you've seen as best practices, or what your thoughts are on how to solve for that.
Yeah. So first of all, it's always hard to be on a panel when there's two mics. I wish my mother would have known that at the time. I'm going to take from context that I was the mic you were talking to, but if not, tug on your ear and I'll just shut up. So I don't have a good answer to this question. It is a very, very challenging question. It is one reason why I tend to think it's important to have a foundational population-based payment model, because I worry that if you try and build a bunch of episode models, you will begin to run into this issue that you arise, that there's multiple people treated by multiple specialists with multiple conditions, and getting the coordination right becomes very, very hard. The solution that I would put forward, although I understand it is vague, is I would err on the side of having fewer models and have models with very clear triggers, procedure type models in places where you think you can add new things. And I would spend less time trying to come up with models to deal with important places to engage specialists and hope that they get engaged by the ACO in a more organic as opposed to formulaic way. So if I'm an ACO, I know a lot of my spending is going to be people with multiple chronic conditions. I understand that I have to engage with the specialists on that. And I believe that type of engagement is going to be very, very context specific. On the plus side, in situations where you have large integrated systems, as Cheryl noted, is an increasing number of places, a lot of the times the primary care doc and the specialists and a lot of other parts of this care delivery infrastructure are under the same roof. And that gives some more flexibility for you to build out the internal compensation and the internal reward and management structures to address your issues. And I would try and keep payment policy writ large as much out of that as you could. As a general point. That's not always possible. So I would lean to, personally, relatively fewer episodes in relatively more targeted ways, and hope that the population-based payment models find ways to work around the challenges that you raise. But in our complicated, fragmented system where a lot of the money and, frankly, a lot of the health decrement is occurring for people with multiple chronic conditions, it's very hard to sort that out through a bunch of episode models, given the complicated sets of overlap.
I would agree with that. And, I think that the organizations that are managing global risk rather than just professional risk tend to be better positioned to be able to manage whatever variety of issue confronts them, to try to do that efficiently. I think what I've observed, at least among the groups that are only taking professional risk, beyond sort of saving on the hospital side, which doesn't affect their bottom line, they have shifted to trying to capitate specialists, again, to try to control utilization. But, that may affect utilization, but it doesn't necessarily address coordination of care for people with multiple chronic conditions. So it's kind of a quick fix, but it doesn't necessarily address what I would call optimizing quality of care for individuals with multiple conditions.
I guess maybe adding on and addressing the other mic on this topic of coordinating specialists and PCPs, is there something We can learn from the MA plans related to how they build their provider networks and use payment structures to align incentives of individual providers, i.e. specialists, with primary care clinicians.
My general response is I think this is an area where the health plans can get better. They have analytics platforms and they look at referral patterns. They look at within the network which providers are ultimately creating the best outcomes, whether they be particular quality measures for STARS or whether they be things like avoidable readmissions. But I don't think the plans are by any means at their climax level of maturity in terms of network steerage and network leakage. I think this is a place where they are getting better. The data is getting better. The contracting and incentives have only just started to get better.
I know we're actually over sort of our time. I don't know if there's any, before we close out with our panelists and move on to Larry's presentation. Any other questions from the committee? I mean, we would really like this to go a long time because we'd love to continue this conversation, but we know we have some time limits. Any last minute questions from the committee?
Paul, I do have just one quick question for Mike Chernu, because I appreciated your summary of the evidence around population-based versus episode-based payment models, and I understand kind of where you're landing on that. Looking forward to our June PTAC meeting, we're going to be talking about care delivery model innovations that support the overall population-based total cost of care objectives. And I'm wondering if there's any evidence whether episode-based or disease-specific based payment models will support increased care delivery innovations around that specific disease or episode. I think from a care delivery perspective, it would be much easier to focus on.
Yeah. So I think the short answer is yes, there is. It's episode dependent. So lower extremity joints is going to do better than certain other areas, but sometimes the episode models haven't been exactly optimized in a bunch of ways. So there's always this concern that you look at what's happened in the past and you say that's what's going to happen in the future in these models. But of course, I think what you think a lot about, what others think a lot about is, well, did you get disappointing results in, I don't know, I'll pick an area, gastro, and I'm not saying there are disappointing results, I'm just picking an area that's not joint. Did you get disappointing results because it will not work in that clinical area? Or did you get disappointing results because you didn't design the model in some way? So in a lot of places, oncology, for example, attribution is a huge problem. So is the issue there that we haven't got the attribution models right to the episodes, or is the issue that it's just hard to work in oncology? It's hard to know. The question becomes, if you keep experimenting and you layer it through different settings, so the ability of any of those models to achieve success depends on, are they put in the context of an ACO model? Are they put in the context of an ACO model where the organization includes the specialists? So much of the right reactions or the reactions you're going to get are context specific, environment specific, that it's really hard to generalize. I think there is clear evidence that episodes can work. And frankly, there's clear evidence that for a bunch of reasons, in certain cases, if you add episodes on top of an ACO, you will grow the pie of savings. But there's also evidence that that is not uniform. And the question is, how do you figure out where it works and how these things don't bump into each other? Again, I feel like that was a little bit of a general answer, but maybe it was helpful.
Thanks.
Great. Well, I think we have time for one more question. Chinny?
Yeah, I wanted to actually address Chris and also the other Mike, Edelberg, because, one thing we haven't focused on is sort of what you guys touched on with patient literacy and their knowledge of the healthcare system. And particularly in Medicaid, Chris, I know that it's very hard to engage patients. It sounds like you guys have cracked the nut on it. I'd love to hear from you guys on some best practices there, as well as ACOs swing a lot, and that's a challenge, right? For when there's not assignment for health systems. So how do we solve for that when we design a payment model?
So I can't address the last one around attribution, which is I think what you're getting at, but the former with regard to patient engagement. The CCOs have a requirement to that each of them needs to have, and this is in legislation, a community advisory council that is comprised of at least 51% Medicaid members and then other representatives from the community and community-based organizations. And this model, while not perfect, has certainly gone a long way with regard to kind of engaging members in the design of the CCO model, and especially where the CCOs invest in those health-related social needs and also addressing more system-wide social determinants of health. So that's a model that I would say you can look at and look at spreading. I mean, it's kind of similar to the FQHC's requirement of the Patient and Family Advisory Council, the PTACs, but it's at the system-wide. And actually, the last thing I'll say about CACs is their kind of directive is not just it's to advise the CCO on the health, not just of the CCO's members, but of the whole community. And they are tapped with developing a community health improvement plan for the community based on a community health assessment. So the CACs have quite a large role, and it's been relatively successful.
Just building on Chris's very good comments, because healthcare is so expensive relative to ancillary services you can build on top of it, there are a number of plans in Medicaid and MA that are investing in various types of concierge programs. So whether it's a community health worker, whether it's a Papa Pal, a national rent-a-grandkid platform, the idea that you are going to deploy someone who will assist and nudge a subset of your membership, people with high needs, to navigate the system more successfully and to be a resource in navigating the system more successfully. These interventions are very inexpensive relative to the cost of healthcare, and if they do lead to gap closures, I suspect their ROI is pretty good, as well as outcome improvements. To Mike's comment, it shouldn't only be about money.
Can I just add one final comment on this patient engagement piece? So I'm going to share like my own direct experience as well as those of people around me who allegedly have been enrolled in ACOs. The communication between the ACO entities, so the plan and the physician organization, to the member, and very cryptic, not easy to understand what it is you're in. But additionally, we've seen no evidence of any change in care delivery or access. So I think a lot of this is not clear to the consumer, the patient, the beneficiary, that they are in anything different and that their care experience will be anything but per usual. So I think that, we clearly need to better understand what it is we're trying to engage patients in, and how that interaction with the care delivery system will be different. But I think right now it's very opaque.
So I've been texted, we actually have a few more minutes, and we hate to have this panel go if we have some additional questions from the committee.
I have sort of a tangential question. So what I've seen working a lot in the underserved population space is a massive proliferation of venture capital-backed risk-based models. And I was curious what each of you think about those and what lessons we might be able to take from those as we look at the next phase of total cost of care model design.
Well, we're in private equity, getting into buying up practices. Mike, you may have more evidence on this. I know Medpack's been looking at this, but I think there's this other issue that your question sort of prompts for me that I've been hearing from providers in that, you know, with this vertical integration that I was speaking about for the independent physicians who remain in the community, who serve a lot of these disadvantaged patient populations. And it's making it so they don't have the cross subsidies from the commercial side that they used to have. And so they're finding their kind of risk position to be pretty bleak and not sure how they're going to continue to serve the patients in their communities. So again, I think, you know, kind of in this larger look at payment models, I think we have to figure out how we get to greater equity across these different payment platforms. You know, with the commercial insurers paying, you know, large amounts more than Medicare, and Medicaid sort of struggling to provide services and provide access to people.
I agree with that. I wish I had better insights. I mean, one of the challenges here is that, broadly speaking, as the delivery system changes, I'll say this differently. The core value in the healthcare system is coming from the delivery system. Like, financing matters, but what you really want is a good doctor, you want a good hospital, you want a good nurse, you want a good post-acute care setting, you want the right technology applied in the right time, you want to be able to get there. It's all about how we deliver care. A healthcare system, the goal is to promote health. Financing can facilitate or become a barrier to that. As the healthcare delivery system changes for all these reasons that we're talking about, the overall environment that we're overlaying this financing on changes. That has ramifications. Because our financing is fragmented, it is difficult to provide a consistent message, if you will, to this underlying delivery system. And the underlying delivery system is sort of, I'm going to call it the golden egg. I don't mean that, given maybe, I don't know, got some issues with it. But the point is, it is the core source of value is the delivery system, and how we facilitate its health and its ability to innovate and produce care efficiently is the core that we need to accomplish in these payment models. Fee for service, I think, inherently doesn't do that, but moving into an alternative payment model in a fragmented way, as was pointed out, I think the very first question was they don't have enough patients in that model anyway. They're not going to be able to change. And I think Cheryl said that on one of her slides. So I think there's some notion that that's where you have a problem. And when you have other things going on in that system, fragmentation, consolidation, different types of organizations buying up other organizations, exploiting the loophole in every rule you put in place, it becomes even more challenging. And I don't know how much longer we have, but I hope we don't end on that depressing note.
Mike, I think you have a comment.
I'll be brief. I don't think private equity of itself is something we should seek to exclude from the healthcare system, but to the degree that that private investment seeks the most profitable niches and then leaves the least profitable niches for legacy entities, that's a public policy problem, and we should be worried about that.
And just, Chris, I'm wondering if you see a different proliferation of VC-backed models in Oregon because of what you have in your structure.
That's a good question. I don't have line of sight into that. We're pretty locally based. Many of our health plans are based in Oregon, so I don't think so, but I don't know.
Thank you all so much.
Yeah. But private equity can occur in the delivery system, and it can be terrific. You can see, a bunch of new primary care organizations functioning, a lot is going on in telehealth, a ton's going on in mental health, which is an area of unbelievable need. I'm sure there'll be a lot going on in social determinants, and private equity can also get involved in the financing side in a whole range of ways. Again, doing very innovative things to be consumer-centric and engaging patients and solving some of the problems we've mentioned. There's a lot of ACOs and organizations that have been private equity financed that enable and support delivery system transformation, and some maybe not as valuable. I'm not trying to make judgment, but private equity, like many things, can be both good and bad.
I think the big trend, huge change in the last 6 months, especially related to Cali, so Medicaid redesign in California, I've been approached by so many different companies looking at taking on the homeless population as a total cost of care model, or the criminal justice population, justice involved as a total cost of care model. So it's just made me think differently about where we're going and what kinds of competencies and things we need to be thinking about in building a really just and integrated system for the next phase.
That's great. So with that, I want to thank everyone, the presenters, excellent presentations, excellent discussion. You're certainly all welcome to stay and listen to the remainder of our meeting. We'd certainly love to have you stay on if you can. But we're going to move to the PTAC member listening session. Larry Kaczynski, who is one of our PTAC members, will be presenting on how specialty models fit in a total cost of care context. So, and then please have questions ready for Larry after his presentation. So Larry, I'm going to turn it over to you.
All right, thanks, Paul. Okay. Well, as Paul said, my task is to discuss the role of specialty models in reducing total cost of care. I'd like to thank the PTAC for giving me the opportunity to speak today about my experience in taking an idea that started from a clinical observation to then become a project that was presented to PTAC for consideration and recommended back in 2017, and has since resulted in a successful commercial venture. I'm talking about Project Sonar, which was the first PTAC-recommended physician-focused payment model back in 2017. We will use it as an example of the role of specialty models in reducing total cost of care. Next slide. Our agenda today is shown on this slide. We will begin with a review of Project Sonar, starting with its early development, how it came to be, and the reasons for its existence. We'll then summarize our presentation to PTAC back in 2017 and what happened following the meeting. I will then spend some time on SonarMD, the company that I formed to commercialize this project, and we'll discuss its payment model and its performance in the commercial space. This will lead to a discussion around total cost of care, where we will discuss the multiple commercial definitions of total cost of care using the elephant view as a model. I'll then discuss how the definition of total cost of care affects patient care, and finally try to draw some conclusions. Next slide. So how did this all get started? We have to go back 10 years to 2012, when I was asked to be the chairman of the Practice Management and Economics Committee for the American Gastroenterological Association. This would be a 3-year appointment, and I wanted to accomplish something memorable while in this position. Gastroenterologists, like many specialists, have a very poorly diversified revenue stream. In fact, the great majority of the income realized by a gastroenterologist today comes from performing colonoscopy, one procedure. And most of these colonoscopies are performed for preventative reasons, screening for colon cancer or surveying patients who have a history of colon polyps. Over 60% of the revenue of a GI practice comes from just this one service. Not a very, very diversified revenue stream, and one that is vulnerable to less expensive technological advances for colon cancer screening. I therefore sought to help diversify the revenue stream of gastroenterology and hopefully encourage my colleagues to enter value-based care arrangements in the process. The major significant disorders treated by a gastroenterologist are the inflammatory bowel diseases, Crohn's disease, and ulcerative colitis. Very expensive conditions, $40K per capita annually, with over 2/3 of the per capita cost as disease-specific costs. I decided that these diseases would be the basis of my investigation. I was fortunate to convince a major payer to provide me with claims-level data on patients with Crohn's disease. They provided me a commercial database of 21,000 patients with the disease, claims over a 2-year period. And these are the patients. These patients can become very seriously ill. I already talked about their costs, but they had a 17% hospitalization rate. The investigative physician in me wondered what happened to those patients before each of these hospitalizations. I asked myself, could some of them have been avoided? When I researched each admission for what happened in the preceding 30 days, I had my first aha moment. In over 2/3 of the patients, there was not a single CPT code in the 30 days before their hospital admission. Not an office visit, not a lab test, no imaging. I thought that was quite strange and represented a potential opportunity to build on. We interviewed patients from the data set that were from our practice and heard the same refrains over and over again. I have this all the time, doc. I didn't think it was important. I thought I had the flu. I wanted to call the doctor, but I didn't have time, with work and family and all. It was clear that patients with this type of symptomatic chronic disease were going over the cliff without realizing it. They weren't Crohn's patients. They were human beings with lives who just happened to have the disease. I determined I needed a communication system, a Sonar system, a way to ping these patients in between their face-to-face visits so a medical professional could decide if they needed intervention. Because if we waited for the patient to realize they needed help, most often it would be too late. I created a crude communication system using a patient portal where I sent out some questions from the Crohn's Disease Activity Index to patients. We sent them out monthly. It was cumbersome because everything had to be calculated by hand. But in the calendar year 2013, we had only a 5% hospitalization rate, which was significantly lower than the 17% from the previous claim set. So I went back to the health plan. They were impressed enough to make us their first intensive medical home they had ever done with a specialty group. It was launched in December of 2014. The structure was that every patient had to be touched in some way every month. We used a tech-enabled platform that we had developed to facilitate this level of engagement, but there was a strong human component to it. This was not just an app. Our practice received prospective care management payments to help build a value-based infrastructure, something very critical that I believe in these days. Finally, quarterly claims were available to the practice, which is also essential so we could really see what was happening to our patients. The figure on the right side of the slide shows our first year's performance. We lowered hospital admissions by 57%, ED visits by 53%, total cost of care, which included drugs, by almost 10%. We presented this at Digestive Disease Week, our major GI conference in 2016. The physician-focused payment model was launched later that year, and we immediately filed an application so that we could bring this to the public space and potentially garner a 5% bonus from Medicare. Our proposal went through the usual 4-month process and was presented to PTAC in April of 2017. It was approved by PTAC and recommended to the Secretary for limited scale testing. The Secretary, though, decided not to pursue our model since it was using a proprietary technology, but stated that it would consider input from this proposal when developing potential models in this area. We were disappointed, but understood. A commercial venture was now in our focus. Next slide. Sonar was formed in February of 2018 as a venture capital-backed company. We are a tech-enabled care coordination solution for patients with symptomatic complex chronic diseases. We're currently deployed as a solution for multiple GI illnesses, but only GI, and are contracted in multiple states. The way our solution works is shown in the clinical wheel on the right. We receive an attributed population of patients from a health plan, patients who have inflammatory bowel disease and now several other diseases. The disease-specific cost, as I said, of IBD is 2/3 of total cost of care. So a specialist's work is very important here. An important point is that a gastroenterologist, on the average, only realizes $400 a year from taking care of a Crohn's patient, a patient with a $40,000 per capita cost. We have to work to get those gastroenterologists out of their GI labs where they're performing colonoscopies on healthy patients and focus on the care of these ill patients, which means program design. So we enroll patients in the program performing a three-pronged risk assessment, disease severity based on disease-specific metrics, but patient engageability assessments, placing patients in cohorts of engagement so that we can communicate them in the way they prefer to be communicated with. And finally, using a claims-based assessment of existing doctor-patient interactions. And we're building this over time now with machine learning. The patients are then engaged using our platform on a monthly basis. Care coordination is performed by a human being, by a member of our staff. If symptom scores exceed benchmarks, we then alert the practices to their potential deteriorating patient using a structured format. Our goal is to work as an extension of the practice and not disintermediate the doctor-patient relationship. The intervention taken by the practice is then fed back to us so we can continue to improve our data-driven risk assessment. Next slide. This is probably the most important slide. It demonstrates our payment model, and I have to say it has significantly matured since our PTAC presentation in 2017. Sonar MD occupies a position between the commercial health plan and the specialty providers. We provide flexible, value-based arrangements for the health plan where we guarantee them a minimal savings, above which we share equally with them. They do provide us an advanced performance payment, which we're on the hook for, but which we use to both fund our operations and share with the practices so that we can help them build a value-based infrastructure. As I said earlier, this is critical. If the practices do not have an existing structure for value-based care, many of these practices don't even hire a nurse. Risk is aggregated amongst the practices for each health plan, so we get some benefit from the larger numbers. There's no downside risk at this time for the practices. That's an aspirational goal of ours for the future. Sonar bears the downside risk. Next slide. We continue to show the same success we demonstrated early on. This slide shows a difference of differences study against a propensity match control group a few years ago. We demonstrated again a 15% savings in total cost of care, including drugs, both on the medical claims as well as on the pharmaceutical claims. This was driven by declines in inpatient admissions, ED visits, and non-ER outpatient expenditures. The savings on those components is much higher than 15%, but the total cost of care declines 15%. We recently had a reconciliation from one of our large plans, and the savings was again demonstrated in 2020. Next slide. So using the elephant analysis, total cost of care depends on your view. Like the example of the elephant, it all has to do with how it looks to you. Most health plans today, commercial health plans, focus on medical costs. This may or may not include provider-administered drugs like biologics, since in most cases, 2/3 of the patients are funded by self-funded employers, and PBMs may be different than that of the health plan. The PBMs, of course, are focused on these costs. Provider focus is specialty dependent. If you ask any of my GI colleagues, what's the most expensive component of GI care? They will all say colon cancer screening, because that's their focus. ACOs mostly focus on medical costs, but not pharma costs. The patient is concerned about their out-of-pocket expenses, their copays, their deductibles, what's coming out of their pocket. Employers who don't bear risk are concerned with insurance rates, whereas self-funded employers are truly concerned with total costs, similar to CMS. Next slide. So how you define total cost of care can affect patient care. Business model conflicts can arise. Is the juice worth the squeeze? What percentage of your total revenue is represented by the alternative payment model? If not enough is at risk in the value-based arrangement, there's no incentive to change. Fee-for-service revenue versus value-based care revenue must be changed out of the balance it's in right now and put into a balance that favors value-based care, or we're not going to get buy-in from the providers. Should fee-for-service rates be frozen, making value-based revenue the only driver of additional EBITDA for practices? There are potential direct patient care effects. Site of service drivers for outpatient services can push patients to specific sites. These may or may not be desirable for the patient. Route of drug administration, Part B versus Part D. If I'm not on the hook for Part D drugs, I can play that system and push patients off Part B drugs onto Part D drugs. If total cost of care is not the metric, then this can be played by the providers. There are infrastructure issues. Does the institution have the infrastructure to manage the care? Is the institution large enough to manage the risk? Whose responsibility is it to decide this? Next slide. Total cost of care needs to be defined so that risk can be managed. Accountable entities can be defined appropriately for managing the risk. Care can be optimized for value from a patient focus. Skeletal infrastructure must be defined. Risk should not just be transferred. Who has the obligation to the beneficiaries that the transferred entity can handle the care? Skeletal substructures need development for specialist participation. Can we build nested solutions? Can we limit carve-outs? We don't want to be creating a structure like the condo building shown in this slide in Florida that collapsed last year because the responsible party for maintaining its structure was incapable of making the necessary decisions to maintain it. My final comment is, can PTAC's review of proposed physician-focused payment models become a vehicle for evaluating stakeholder-submitted approaches that have the potential for deployment as nested solutions in population-based risk entities? Thank you.
Great. Thanks, Larry. That's a terrific presentation. So we're going to open it up now for questions and discussion from our committee members. So certainly you can raise your hand in the WebEx or just go ahead and ask a question.
This is Bruce. I did raise my hand. And I have a question for Larry. I'm sort of thinking back to the previous panel, and I think it was Michael Chernu in particular who expressed some concern about the proliferation of episode or disease-specific models. And I think I went on to say that he thought that programs like yours, Larry, that have been shown to be successful could be integrated more organically, I think is the word he used, as opposed to, I'm not sure what the opposite was, but I'd like to get your reaction to that. Do you think that's feasible?
I do think it's feasible, and we are pursuing this. If you look at the GI space, over 20% of the total cost of care is represented by patients who carry GI disease diagnoses. Now, that doesn't mean that the GI disease is the dominant reason for the cost in some of these populations. But we have studied with actuaries the GI population, and inflammatory bowel disease is responsible for over 50% of the variable cost of that space. So we're already halfway there. And our goal is to be able to say to an entity like an ACO or other large population-based total cost of care entity that we can handle this GI component, and we're willing to work at risk. It's too small to say we're going to take care of your inflammatory bowel disease patients. I remember from our PTAC presentation back in 2017, IBD is 1% of the patient population, but 2.5% of CMS's overall expenses. Still too small. It happens to work for us because most of the costs are disease specific, and the primary care doctors are not typically taking care of these patients. There's a firewall there that you can do. But when you get into other conditions like acid reflux or irritable bowel syndrome or diverticular disease, you have to be able to decide what components of those illnesses cost are driven by the GI decision, and the GI doctors should be at risk for those. I'm a big believer in the fact that we need to either freeze fee-for-service reimbursements at their current level and allow only growth to occur in value-based arrangements, but we have to move this in the right direction and encourage providers to accept controlled risk. And I really do believe that's going to come from putting episodes together nested in larger entities.
Thanks. Okay.
Other questions? Larry, I'm curious how you think about subspecialty within your thinking. You know, certainly in many GI practices, there are one or two gastroenterologists who focus on inflammatory bowel disease, yet they may be in a much larger group. Similar in other specialties, certainly in my specialty in cardiology, I feel in some ways this subspecialization almost works against us as we're trying to move towards this total cost of care. I'm just reflecting on that in your experience. How do we try to manage that within the context of this move towards subspecialization?
That's a great question, very pertinent. I want my best colonoscopist. If I'm running a GI practice, and I did, I participated in running the largest GI practice in Illinois. I want my best colonoscopist in that GI lab doing colonoscopies. I also want doctors who are focused on IBD to be taking care of the IBD patients. And maybe the value-based revenue that's coming from an agreement like this goes only to the doctors who are actually taking care of the IBD patients. We have the same issue with hepatology because it isn't compensated as well as the procedural services. So I think the payment models have to be structured with the patient's best interest in mind. You don't want every gastroenterologist taking care of IBD. You don't want that. If this is too serious of an illness with too much potential for morbidity and cost to have every doctor feel like he's an expert, he or she is an expert in taking care of it. I think we need subspecialization. We just need to adjust our payment models within our practices so that we compensate appropriately.
Great, thank you. Other questions for Larry?
Larry, great presentation. One of the questions I had was, how do you in this model navigate the drug cost? Besides, obviously managing through the physicians that can prescribe the drugs, but, for example, site of service with where their infusions are done, how do you navigate some of those challenges that lend itself to high cost?
Well, that's what I was referring to in one of my bullets, where the risk-bearing entity will control where the patient is having their services provided. So if someone's part of a hospital-based ACO, they're going to get their infusions in an expensive hospital outpatient department. Whereas if it's a provider-based ACO, in all likelihood that patient's getting it in an office-based setting where the costs between these two are miles apart. So we have to, I think it all comes down again to the model and how you're compensating for certain things. And, having sat on a hospital board, I know how important it is to the hospitals, to have those revenue streams. One thing I think I have to say is my presentation of Sonar here was my presentation. This isn't a PTAC endorsement of Sonar or a PTAC-driven presentation. This was just my ability to present from the provider's point of view what it was like to go through the PTAC process and what happened after that.
Other questions for Larry?
See, I told you we'd get it in time, Paul.
Larry, as you've heard from other specialties and who are thinking about models and look to your model around the country, do you see your type of structure something that can be reproduced for other specialty models?
Yes, with these following criteria. I published a paper in gastroenterology a couple of years ago raising something I called the high beta concept. We're all familiar that in a stock portfolio, you have high beta stocks and low beta stocks, and you can make the same analogy for a family of diseases. So if you look at the GI space, there are some conditions in gastroenterology that are high beta. IBD is one of them. It has high variability in cost, and as opposed to others which are very low. They exist in other specialties as well. In cardiology, congestive heart failure would definitely be one. In pulmonology, asthma, COPD are definitely high beta conditions. The metabolic conditions, inflammatory diseases like rheumatoid arthritis and lupus and that, they would fall into it. The key here for what we're doing is they have to be symptomatic diseases. They have to be conditions where patients' symptoms can be used to help you decide when patients need intervention. And we're not doing anything really sophisticated here. We're just getting patients to care earlier in the course of the deterioration of their illness. And when you work off the concept that most symptomatic chronic diseases are going to fall into that kind of category, if you find the ones that are high cost, high variable cost, that are symptomatic, they should benefit from this type of a structure as well.
Great. Just adding on to that, and this is somewhat anecdotal, because you mentioned COPD. When we did a pilot around COPD, it turned out that a lot of the cost was actually driven not so much by the COPD, but by SDOH and behavioral health issues and such. Do you find in your population that those also are cost drivers that you need to address?
We just published an abstract that's going to be at this May's Digestive Disease Week, looking at the difference in total cost of care of patients who answer a PHQ-2 evaluation at enrollment positively. There was a statistically significant increase in cost, not from the patients who had a history of mental health disorders, but in the patients who answered that PHQ-2 positively. They have active problems. They may not be carrying a diagnosis or not, or if they have a diagnosis, it might be under control. But we're finding evidence of active psychological motivations that's affecting their cost of care. So the answer is yes, very definitely yes.
Great.
Just a follow-on comment for that, Larry. I think clinically, I've seen that across the country, the association between domestic violence and trauma, especially with GI and IBS. So I was just really curious how that maps for you.
We can talk about that for a long time. Definitely.
Okay, great. Well, we're at time at 1:30. Larry, can't thank you enough. Great presentation and great discussion. So we're going to take a break until 2 o'clock. Then we'll come back. We'll discuss what we've heard, and then we'll be done for the day. So we'll see everyone back at 2 o'clock.
Produced by the U.S. Department of Health and Human Services.